So, what is jaundice? Before going to the actual definition of jaundice, we have to differentiate some closely related terminologies like hyperbilirubinemia, jaundice, icterus, cholestasis. So, first is hyperbilirubinemia. By definition, bilirubin level is in the body is more than the normal level is called hyperbilirubinemia. The normal level is zero point 0.2 to 1.2 milligram per deciliter. So in the graph, it is clear that the normal value is 0 to 1.2. So anything beyond 1.2 is called hyperbilirubinemia. If the value is between 1.2 to 2.5, we won't be able to detect it clinically. So if the value is raised above 2.5, we can detect clinically. So in jaundice, the definition is yellow discoloration of skin, mucous membrane, interstitial fluid, and sclera due to hyperbilirubinemia, usually above 2.5 milligram per deciliter. And another terminology is icterus. Icterus denotes yellowish discoloration of sclera due to hyperbilirubinemia. Sclera is especially love the bilirubin because one is it is white in color, so we can easily detect the yellowish discoloration compared to the other body parts. And another important part is that scleral connective tissue molecules loves to by bilirubin. And another terminology is called cholestasis. That means obstruction with the bile outflow system at any level, drainage of bile will be impaired. So that is called cholestasis. There is stasis of bile. Bile will be regurgitated into circulation and causes hyperbilirubinemia and jaundice. So that's all about the terminologies regarding the jaundice. Now, before going to the actual mechanism of obstructive jaundice, we have to understand how the metabolism of bilirubin occurs. So, bilirubin metabolism starts from the it is actually comes from the breakdown of RBC. As we all know that older RBCs are breakdown in the spleen, liver, bone marrow, and normal RBC breakdown occurs within the macrophages of this spleen, liver, bone marrow, etc. So let us consider this is a spleen, and we have a macrophages in the spleen. So one of the let's consider one of the older RBCs gets trapped in the macrophages inside the spleen. So the RBC contains these three parts. One is membrane, and the cytosol of the RBC contain enzymes, proteins, and of course one of the main component of RBC is hemoglobin. Remember, RBC is devoid of nucleus. So the metabolism of membranes, which a major part of the membrane is lipids, which is converted into free fatty acids, and another part is proteins, which is end up in amino acids. Just like that, proteins and enzymes also break down into amino acids. So these two products are reused in the body. Free fatty acids and amino acids reused in the body. So the remaining thing is hemoglobin, which is composed of heme and globin. So heme is made up of these rings called pyrrole rings. The structure of heme is like four pyrrole rings connected to each other is called protoporphyrin. If an ion is added in the center of protoporphyrin, it is called heme. And one globin molecule is attached to the heme, then it is called hemoglobin. From the hemoglobin, globin is a protein part and it is metabolized as amino acids. So this is the structure of hemoglobin, a heme and a globin chain. As I said, globin part is a protein and is metabolized as amino acid, and that is gone. Now the remaining structure is heme. From the heme, the iron is taken out and it is combined with a protein called apoferritin, and this protective heme, that is iron plus apoferritin, is called ferritin. Ferritin is the storage form of iron. Numerous ferritins are polymerized to form a structure called hemosiderin, which is stored in the different part of our body and is reutilized. And what is remaining is called a protoporphyrin ring, but the metabolized protoporphyrin ring is called biliverdin. So this is the initial form of bilirubin, and biliverdin is converted into bilirubin. So let us see what are the enzymes involved in this process. From that is a protoporphyrin is converted to biliverdin with the help of a enzyme hemoxygenase, and biliverdin is converted into bilirubin with the help of biliverdin reductase. So we saw that how hemoglobin is formed and how it is metabolized in our body and the formation of bilirubin. So from the spleen, bilirubin is reached into the circulation, that is systemic circulation, And in the systemic circulation, the bilirubin is in the form of unconjugated, because conjugation occurs only in the liver. From systemic circulation, unconjugated bilirubin reaches to the liver. From the liver cells, unconjugated bilirubin is converted into conjugated bilirubin with the help of enzyme called glucuronide transferase. And this conjugated bilirubin is transferred into the drainage system of the liver, that is right and left hepatic duct, and it is traversed all along the way to common hepatic duct and cystic duct and stored in the gallbladder, and it is expelled into the intestine whenever it is required through the common hepatic duct. From the intestine, conjugated bilirubin is converted into urobilinogen with the help of some microbacteria, and urobilinogen is again converted into stercobilinogen, which is responsible for the yellowish coloration of the stool. And part of urobilinogen is taken up by the liver through the portal circulation, that is called enterohepatic circulation, and some part of the urobilinogen is eliminated through the kidneys. So that's all about the metabolism of bilirubin. So let us see what are the causes of obstructive jaundice. Obstructive jaundice broadly classified into intrahepatic and extrahepatic. So today we are mainly focusing about the extrahepatic obstructive jaundice. So these are some causes. Any obstruction along the passage of bile from liver to intestine can cause obstructive jaundice. So it may be a stone in the common hepatic duct, common bile duct, or these are some malignancies like tumor in the hepatic duct or bile duct, or tumor in the head of pancreas, or ampulla of Peter or periambulary carcinoma, or some periportal nodes. All these can cause obstruction of bile flow and cause obstructive jaundice. So while classifying the causes, so these are some congenital causes, that is biliary atresia, choledochal cyst, and inflammatory causes like ascending cholangitis, sclerosing cholangitis, and some obstructive causes like common bile duct stones, biliary stricture, parasitic infestation, and neoplastic causes like CA head of pancreas, periambulary carcinoma, cholangiocarcinoma, Klatskin tumor, extrinsic compression, that is outside the wall, that is compression by lymph nodes, tumor over the CVD. So let us see some important causes individually. One is gallstones. So these are the predisposing factors for a gallstones. One is fat fertile female, diabetes mellitus, and in old age because of increased cholesterol level, decreased bile acid and pool, decreased bladder motility. All these are predisposing factors of gallstone formation. And another thing regarding the gallstone, that is called a Mirzi syndrome, that is obstruction or stricture of the common hepatic duct as a result of extrinsic compression by a gallstone in the Hartmann's pouch. So these are the types of Mirzi syndrome usually seen. One is extrinsic compression of common hepatic by a large stone in the Hartmann pouch, that is type 1. In type 2, the stone has eroded into the hepatic duct to form a fistula involving less than 1/3 of the circumference. And in type 3, the fistula involve 2/3, and in type 4, the wall is completely destroyed. That is called type 4 Mirzi syndrome. And another triad regarding this gallstone is called Sainz triad, that is gallstones, diverticulosis of the colon, and hiatus hernia. After gallstone, another important cause of obstructive jaundice is common bile duct stone, that is CBD stones. These are broadly classified into primary stones or secondary stones. So what is primary stones is, it is a stone primarily formed in the bile duct itself, and these are usually brown pigment stones. And in secondary stones, usually formed in the gallbladder, and it enters into the CBD, and these are usually cholesterol stones. These are the clinical features of CBD stones. One is called Charcot's triangle, that is a CBD stone causing cholangitis, which may cause pain, jaundice, fever, and these three things are called Charcot's triangle. And sometimes a patient present with a Raynaud's pendant. Other than the Charcot's triangle, patient may have septic shock and mental status changes. And another important cause is CA head of pancreas. It may be an exocrine adenocarcinoma or endocrine tumors like insulinoma, gluconoma, etc. And another important cause is periambulary carcinoma, that is tumors in the region of ampulla, lower end of the CBD or duodenum. The most common presentation is, in this case, is painless jaundice. And another sign is called migratory thrombophlebitis, that is Trossor's sign. So let us see the just a differentiation between pancreatic adenocarcinoma and periambulary carcinoma. In pancreatic adenocarcinoma, this is most commonly seen in the head, but in periambulary carcinoma, as I said, it is seen in ampulla, lower CBD or duodenum. In pancreatic carcinoma, they present with only weight loss, so the presentation is very late. And in periambulary carcinoma, patient may present with jaundice, so the presentation is early. Because of the late presentation, the prognosis is very bad in pancreatic carcinoma, but it is favorable in periambulary carcinoma. Resection rate is very low because of the advanced disease in pancreatic carcinoma, but resection rate is reasonably good in periambulary carcinoma. And another cause of obstructive jaundice is bile duct tumors. It may be benign or malignant. Benign tumors are rare, and malignant tumor is called cholangiocarcinoma. Cholangiocarcinoma may be intrahepatic, perihilar, and distal extrahepatic tumors of bile duct. These are the risk factors for bile duct tumors, that is primary sclerosing cholangitis, choledochal cyst, ulcerative colitis, clonorchis sinus, chronic typhoid carriers, liver flukes, etc. And 2/3 of the bile duct tumors are located at a hepatic duct bifurcation, that is called Klatskin tumors. In the clinical features, the most common presentation is painless jaundice. Bile duct cancers are classified according to the Bismuth classification, that is type 1 is located at common hepatic only, and in type 2 involved confluence with involvement of secondary duct, and type 3A involving right secondary intrahepatic duct, and type 2B involving, type 3B involving left secondary intrahepatic duct, and type 4 involve secondary ducts only in both sides. So that's all the cause of obstructive jaundice. Now let us see how to examine a case of obstructive jaundice. The common presentation will be jaundice, fever. It may be either due to cholangitis or septicemia. There may be itching, weight loss or loss of appetite may be there, vomiting may be there, urine coloration or passing pale stool may be there. If there is jaundice, you have to look the duration, onset, progression, whether it is gradual or intermittent, is there associated with pain or not, and if the jaundice is painless, continuous, and progressive, it may be due to CA head of pancreas, and painless, intermittent jaundice, that may be due to carcinoma at periambulary region, and if the jaundice is painful jaundice, it may be due to CBD stone. Fever may be intermittent or continuous. You have to mention the duration associated with the chills or rigor or not. And there may be associated vomiting, and usually the vomiting is unrelated to food intake. In past history, you have to seek any history of previous gallbladder surgery because it may cause bile stricture and causing jaundice. In general examination, patient may have jaundice, scratch marks all over the body, especially of the chest and abdomen. And in examination, look the fullness in the right hypochondrium due to distended gallbladder. It is usually not seen in every individual, seen usually like thin patients. If it is there, look for the movement with respiration. In palpation, the upper limit is usually continuous with the liver, and there may be a slight side to side movement also. And there will be Murphy sign in case of painful conditions. That is usually look in sitting position. There may be tenderness at the Murphy's point, and there will be holding the breath due to pain. Another point is Courvoisier's law. It states that in a patient with jaundice, if there is a palpable gallbladder, it is not due to the stone. That means if there is a stone in the gallbladder, there is recurrent episodes of cholecystitis, and there will be fibrosis of the gallbladder. So the pathology is there outside the gallbladder due to CBD carcinoma, pancreatic carcinoma. We can palpate the gallbladder. There are some exceptions of this law. One is double impacted stone, that is found in CBD and cystic duct, oriental cholangiohepatitis, pancreatic calculus obstruct in the ampulla of Vater, mucosal due to stone in cystic duct. So these are some exceptions of Courvoisier's law. So let us see what are the investigations to look for the diagnosis of obstructive jaundice. These are divided into biochemical investigation and imaging investigation. In biochemical investigation, one is to look the level of total bilirubin. This usually exceeds 2.5 milligram per deciliter. There will be a direct hyperbilirubinemia in obstructive jaundice, and there may be alkaline phosphatase elevation more than 10 times of the normal value, and there is also gamma glutarate transferase elevation, that is GGT elevation, and there will be a increased prothrombin time because it measures the rate of conversion of prothrombin to thrombin, which usually require vitamin K dependent clotting factors, that is 2, 7, 9, 10. In the absence of bile salt, this vitamin K absorption is not occur, so there will be a deficiency of vitamin K, and this causes prolongation of the prothrombin time. So injection vitamin K normalizes the prothrombin time. In urine examination, there will be absence of urobilinogen, that is obstruction to the common bile duct. If there is excess urobilinogen, it means hemolytic jaundice. And in absent bilirubin in urine is indicated hemolytic jaundice. Excess bilirubin indicated obstructive jaundice because of the conjugated hyperbilirubinemia. In stool examination, there will be absence of bile pigment, and it may cause clay-colored stool. It indicates the biliary obstruction. So, and in ambulatory carcinoma, there will be a positive occult blood stool. These are the two tumor markers of one is CA99 and CEA. CA99 is usually elevated in CA head of pancreas, and CA is usually elevated in cholangiocarcinoma. And coming to the radiological investigation, first thing is ultrasound. This is simple, convenient investigation. It usually look any dilatation of the CBD. The normal diameter is less than 8 mm. If there is dilatation of CBD and pancreatic duct, it may be usually may be due to CA head of pancreas, and it is also helpful to look for the any biliary stones. And ultrasound is also helpful to do any liver metastasis. Look for any intrahepatic biliary radical dilatation, and look for any free fluid in the peritoneal cavity or any mass lesion. Considering the mass lesion, the USG is less value, so we need another higher investigation, that is contrast enhanced helical CT. It will identify the tumor, and it will also help to detect the size of tumor, infiltration to adjacent structures, and pancreatic duct, bile duct dilatation, nodal involvement. All these can clearly understood from the CT. Another investigation is ERCP. It is usually indicated in the absence of a mass in the CT and the patient is having obstructive jaundice, so better go for a ERCP. It will detect periambulary carcinoma. With the help of ERCP, biopsy can be taken, and some extent lower limit of the tooth can be identified. And in ERCP is also helps to stenting can be done to relieve the jaundice, and we can do a sphincterotomy also to remove the stone from bile duct. Another modality of investigation is endoscopic ultrasound. This is usually done to assess the operability and size of the tumor and involvement of the mesenteric or para-aortic nodes, superior mesenteric vein involvement, and it is also helped to detect hepatic metastasis. Another one is percutaneous transhepatic cholangiography. It is useful in dilated ductal system. In this, needle is inserted under local anesthesia and under the guidance of USG, and it is ideal for demonstrating the anatomy of the biliary tree. Then upper GI series, like the classical findings are widening of the C loop of duodenum in a case of CA head of pancreas, or reverse 3 sign in case of periambulary carcinoma. So that's all about the investigation. So coming to the treatment of obstructive jaundice, it is broadly classified into operable and inoperable. Most of the CA head of pancreas cases are inoperable. If it is operable, the treatment of choice is pancreaticoduodenectomy or pylorus preserving pancreaticoduodenectomy, followed by the anastomosis of pancreaticojejenostomy, choledocojejenostomy, or gastrojejenostomy. So in inoperable cases, the signs of inoperability clinically is presence of supraclavicular nodes, ascites, rectal shelf of Bluma, that is rectal deposit on PR examination, presence of liver metastasis. And preoperatively on investigation, the presence of ascites, liver mets, peritoneal metastasis, rectal deposits, involvement of portal vein or superior mesenteric vessels also is signs of inoperable CA head of pancreas cancers. If in inoperable case, we have to go for some palliative surgeries like to relieve jaundice. For example, cholecystogegenostomy, that is gallbladder anastomosis with jejunum, and relieve duodenal obstruction by duodenal gastrojejenostomy, or self-expanding metallic stent insertion by endoscopically. And in inoperable case, the pain is managed by transthoracic splanectomy, that is dividing the splenic nerve transthoracically with the help of thoracoscope. And chemotherapy is also helpful in case of carcinoma pancreatitis. These are the two agents usually used. That is, one is 5-fluorouracil and gemcitabine. The prognosis is the median survival is only 20 weeks, and less than 3% of patients survive 5 years in a case of CA head of pancreasis. Let us see what is the management in the case of CBD stone. If the stone is less than 2 cm, an endoscopic sphincterotomy can be done, followed by laparoscopic cholecystectomy done, preferably in the same sitting also, or laparoscopic cholecystectomy and laparoscopic CBD exploration can be done, or an open laparotomy cholecystectomy followed by CBD exploration and stone removal. And management of a case of bile duct tumor, as I said, most of the tumors are malignant. Benign tumors are rare. That is, cholangiocarcinomas are most common. A palliative sending or surgery can be done. In surgery, you have to make sure the patient is fit for the surgery and at least getting a 5 millimeters of clearance. And reconstruction done by Rowan by hepaticojejunostomy. So far we have discussed the metabolism of bilirubin, cause of obstructive jaundice, clinical features, investigation, and management of different causes of obstructive jaundice. So this is all about the obstructive jaundice. So